Hello, everybody. My name is Dr. Samy Allam, founder and CEO of DextroMedical. Welcome back to the deep CDI dive. And today we'll be talking about a very important topic, which is moving from bedside medicine to data-driven medicine. Data-driven medicine is the missing link in modern residency training. And today we'll discuss a little bit more about the dynamics of clinical documentation integrity and residency training. We'll do a deep dive. If you're interested in the topic, subscribe. There will be more information regarding that moving on. So what is it that we're trying to stress on? We train residents for the exam, but the hospital requires more of the operational fluency. So we teach them differential diagnosis, we teach them treatment algorithm, we teach them procedure terminology and clinical reasoning. But unfortunately, we do not teach residents hospital operations and patient outcomes and risk adjustment and quality metrics. And with that comes a lot about the information that is being required to be inputted in the patient medical record system. Each patient should have an alter ego when it comes to the severity of illness or risk of mortality. There should be a digital copy on the medical record for each patient. Because as we have mentioned before in prior videos, the system believes the chart. And if the chart is not accurately documented, the codes are not going to be inputted correctly. And the medical claim will come back with denials and false risk. That's something that you don't want. But we're not here to teach physicians how to be good coders. We teach them how to do good clinical validation, to understand patient outcome, and also make sure that we teach them that by example. And again, I'll stress back about a sick patient that comes to the hospital. And here's a good example. Mentioned before in prior episodes, a patient that has malnutrition, famous malnutrition scenario. Patient came in, resident documents that the patient has a poor intake. System interpretation of that will show that the patient has low risk. And of course, the outcome will be preventable mortality, as opposed to another scenario, the resident who was documenting the information correctly. The resident documentation says that the patient has malnutrition. The system interpretation, when you put the information into the patient chart, it shows that this patient is high risk and high severity, rightfully so. And the outcome shows that the patient has accurate expected outcome and the risk is being adjusted. Same patient. The clinical outcome is the same. The only variable is the translation of intent into the data. So the documentation as an input. And right now in the modern AI era where everybody is expecting to perfect the information and the output, but when the severity is underdocumented, the input is not good. And so the processed information through the algorithm and the coding will not reflect the actual severity of illness and risk of mortality. And the patient would show different complication rates and skewed data. The intersection between the clinical accuracy and the data precision. And this is what we're trying to be informed about. And if you can see that on the screen right now, you can see that there is a circle of clinical accuracy and the data precision. There comes in the middle the patient safety and the patient outcome. You want the care pathway to be stable and not volatile in nature. You don't want your patient to show that they are receiving suboptimal treatment, and you want to protect the physician's narrative. So you have a well-taught physician, understand the clinical documentation integrity, rules and regulations and concepts. They understand the rules and regulations of CMS when it comes to the expectation of documentation. And you have those who does not have that skill set. So without, and you can see the comparison here, those who are without the CDI skill set, their patients are showing complexity, but the patient dies prematurely on the chart. System sees low risk patient death, but the patient expires perhaps. And the quality flagging goes on and on. I've worked with different hospitals. Those who doesn't have clinical narrative being adjusted preemptively on a concurrent basis by a collaboration with the CDI program that is prompt to initiate the education with them. They suffer from low quality scores. And we talked about the reputational risk before and what that means to a hospital or on the hospital profile. With the CDI skills, You get a complex patient that shows the real severity of illness or risk of mortality, a system that shows high risk mortality, and the patient shows progression that is validated in nature. So it's essential for harmony with legal reviews, with quality committees, and the peer review panels that you have an active CDI program. But what actually we teach in CDI when it comes to the preservation of decision making? You have the clinical moment. This is when the resident come in contact with the patient to abstract the information from the history and physical, from the post-medical history, from the social history, from medication the patient was on, and focus on diagnosis and treatment. But we have that moment where the resident really translate medicine. They translate the information. They say, well, this patient has a temperature that is high, and so they have fever, pain. The pain score was 5. A dull aching pain was there for 2 hours, 2 days prior to the patient's admission, and so on and so forth. They don't really speak the medicine behind the interpretation of that data. A good example for that, patient has a prior admission with sepsis, come here today with a past medical history of organ dysfunction, and presented to the hospital with fever, indicating signs of infection, and you go on about documenting the information. So this is how you speak medicine, and you do not turn into a translator for data. So therefore, and in modern medicine, and we spoke about that before, that we need to focus on how the decision is interpreted by the system months later. So I plan in my mind that I will show the impact of my treatment and also spoken medicine behind that data. I'm not going to be only a translator for medicine. And so in our education here at DextroMedical and the curriculum, we focus on 3 pillars. And those 3 pillars is that we show how to describe the physiology and not just the symptoms in terms of the ICD-10 guidelines. So we move beyond observing the underlying mechanism. You don't want to be just sitting on the shoulder of the road when it comes to the documentation. You want to be involved in driving within fast-paced land. And while you're driving your vehicle in that documentation, fast-paced land, you're observing others. So you're observing the documentation from the consultation, you're observing your peers, and you're trying to make that collaboration visible on your chart. And you want also to describe the risk and not the events. So we teach you how to capture the severity and potential for decline, not just what occurred. And number 3, we describe management thinking. And this is an add-on that we're trying to help others to partake at, especially residents and attending physicians as a team, and they work together as a team for the best output of the patient outcome. And what's the result? The result is good input. As we can see here, and as you've been using the EHR tools in your hospital, and you may be familiar and aware with that term, they say garbage in, garbage out. Unfortunately, if you, and in any machine learning model, if you're putting garbage in, what's going to be processed is garbage, and what's going to be out is garbage as well. And so with poor input, there will be poor output. Even though if it's been trimmed, a poor input will result in poor output. As opposed to, as we can see here, a clean input, if you use it with the right tools, with the right AI predictive models, the human experience will show a physician that practices safely with a good understanding of medicine and a good interpretation of it. So the input must be in harmony with the output. We are developing an accredited ACGME-compliant clinical documentation integrity residency program that not only cater to where it's helping future physicians to understand the risk, but also partake in patient safety and hospital outcome. Thank you very much for attending that today. We'll speak about that later on. If you're interested in that program, please feel free to reach out to us. I will put our LinkedIn information, and thank you. See you next episode.